Nice of you to join us. As I think some of you may know, the Cabinet Secretary for Health of Kenya, Minister Wafula, was called away back to Nairobi, but we are so fortunate to have Governor Abdullahi here with us. Thank you so much for joining us. We really appreciate it. We wanted to talk with you a bit about Kenya's UHC initiative, Universal Health Care. And interestingly, when we speak with the Cabinet Secretary, we'd be talking about the kind of top-down approach, but you provide a really interesting perspective on this as a governor of a district, a rural state, where you'll need to really implement a lot of these policies and can give some perspective on it. So I'd love to kind of understand a little bit more about that, Kenya's journey towards UHC, the recent legislative changes that took place, challenges, and how that's been able to provide affordable and accessible health care. So maybe you could just walk us through a little bit about the legislative changes that took place, overhauling Kenya's health system and infrastructure.
Thank you very much. My name is Ahmed Abdullahi. I am a governor of one of the counties, and I double up as the vice chair of the Association of the Governors. It's called the Council of Governors of Kenya. So healthcare is largely devolved in Kenya, which means the implementation of the norms and standards set by the national government falls squarely on the counties. Actually, the national government runs about 6 facilities. So the rest of the facilities, level 2 all the way to 5, which are something in the region of 17,000 facilities, actually run by the county governments. The UHC, universal health coverage, is largely from the fact that healthcare is a right under the Kenyan Constitution. The Constitution which we promulgated for ourselves in 2010 requires that government actually provides health care to everyone. And it tries to tackle 3 things: access, it tries to tackle quality and cost, basically. And it's been a journey. It's something that started some years back. On the legislation, we now have the Public Health Care Act in place. We have we call it the Primary Health Care Act. We have a Social Health Insurance Act. We have a Digital Health Act. And we have Facility Improvement Fund Act. So these are the 4 pieces of legislation that were passed recently to try and anchor UHC and aspects of it into law.
Okay, great. Thank you for explaining. The new UHC legislation required enhanced contributions from citizens as well as employers, and you got a bit of pushback over that. I was wondering if you could talk a little bit about your experience implementing those changes and what were successful strategies for creating public and private buy-in to ensure that the system is financially sustainable.
Yeah, like all good things, when you try to implement something new, there will, of necessity be some resistance to change. I think it's human nature, because there are a lot of players in the healthcare space, and trying to get onto these new platforms, be they underwriters, of healthcare insurance, there'll be some level of resistance. But in terms of strategy, I think what has worked for us more than anything else is mainstreaming the community health promoters. Under the old system, we had something called CHVs. They were more, voluntary in nature. We used to call them community health volunteers. But now they've been renamed to promoters, and they get some stipend, which is shared on a 50-50 co-pay arrangement between the national and the county governments. We have thus far recruited, quote unquote, 107,000 community health promoters.
Wow. What is a community health promoter? Maybe you could describe how they integrate into the broader health system.
These are people who take care of 100 households in a community, and we usually say the work is threefold: is to prevent, protect, and promote. So what they do is basically explain healthcare and how the system works, and the referral system to the communities. But they also are kitted with basics. You know, they're able to check someone's temperature, their blood pressure, their sugar level, and then also carry basics. For instance, malarial tablets in the malaria-prone areas, and some paracetamol in case someone has a high fever. But they also then explain to this person that their situation is complicated and they probably need to get to a health facility. So they are there in the community identifying who is unwell, who needs help. They also explain antenatal care to expectant ladies and link them to facilities. So, and the whole idea is to move more from the curative to preventive and promotive strategy. As a way of bringing down the cost of healthcare.
And while this sounds very grassroots, there's actually a technology provider that helps implement this, Safaricom.
Yes, they are provided with a smartphone equipped with what is called an electronic community health information system, which provides them with a lot of information, but which also helps them take all the details that they need to then transfer to someone at a facility.
Excellent. Just a minute left. I wanted to kind of dig into some recent crises that have occurred in Kenya, record floods in that really swept across the region, East Africa into the Mideast as well. How does emergency relief and UHC coexist and work together? I'd be interested to know what steps either the community health promoters or other organizations play in these scenarios where you have emergencies that need to be addressed and climate crises.
Yeah, we've had two, initially we had 5 cycles of depressed rains, and then the last 2 seasons were, the El Nino of November, December, and then what the weatherman called the southern Kenya floods, which were, the recent rains, and they caused a lot of suffering and disruption, really, to transportation and displacement of communities. And the CHPs are critical because these are people who are actually able to literally foot in those terrains, carrying the kids on their back and helping people in their communities in the situation in which they're in. And they worked very well with the disaster response teams, with the also with the Kenya Red Cross, and in some places, of course, the military and disciplined forces also had to come in to try and respond to the emergencies. So that they are able to give basic fast response, even in situations where there is either extreme drought and communities, especially among the nomadic pastoralists that are up in the north, or in flood situations like we had recently, because they are part and parcel of the community, was a good thing. Yes, there are challenges, but I think Kenya is on course to give universal health coverage to its citizens. There'll be challenges, there'll be funding challenges, there'll be coordination challenges, there'll be some resistance to change. But we feel on the ground as governors that yes, something is changing and we're all better for it.
Thank you so much. Governor Abdullahi, it was actually really refreshing to get a local perspective on some of these implementations, how community health promoters are really helping to lever UHC. Thank you so much for joining us today. I appreciate it.
Thank you very much.
Thank you.
Next up, a discussion on healthy cities with large